And were you guys asking about turkey ticks or turkey mites or something last? I always tell the story when I did residency in Chicago, and we saw a kid with chigger bites, and they had no idea what that was up there. And so I was one of the only people from south of Indiana, basically, in Chicago, and I was like, that's from a chigger, and people were like, what? Like, it's a chigger bite, like a chigger bite, and you're like, blank state, like, what are you talking about? And it was kind of the way I was for the first time I had somebody come in and be like, I have turkey bites or turkey ticks. So some of that is reasonable. But anyway, as you said, I flip-flop with Dr. Patel, so if you want to flip ahead to where we are, you'll see this stuff later. And I think she told you that I'm one of the pediatricians that is in the same department as Dr. Pendleton and Dr. Terrio. And you guys are, I want to understand kind of where you guys are coming from. You guys are all school health nurses from Kentucky, as far west as west can go, and as far east as east can go, pretty much everywhere in between. Okay. All right, so we're going to talk about the sports physical, or the fancy term for that is now the pre-participation evaluation. And obviously, we're focusing on children and adolescents today. So, okay, so what are the objectives of the sports physical? So know that everybody in the room is going to have different goals or objectives. So the athlete wants to get their paper signed and go play. The parent wants to, hopefully they want to ensure their kid's safety. The provider may have different goals. So think about that. The institution requesting the forms may have legal and liability requirements for them to take care of. We need to, as the provider, provide assurance to the coaches that the kid's going to start the season at an acceptable level of fitness and health. We also look at it as an opportunity to discuss other health issues, other anticipatory guidance, that kind of stuff. And this brings up the idea of what is the question, what is the ideal setting or location for the sports physical? Ideally, it'd be with a provider that knows the patient or the athlete. How many people would say that they're basically the medical home for a decent percentage of their children? So okay, good. So ideally, this isn't taking place at Kroger or some kind of walk-in clinic. And, somebody that knows a little bit about the patient, maybe even the family, that kind of stuff. Ideally, not that. I realize sometimes that's not possible. You can also look at it as a way of predicting and preventing future injuries. Talking about injury prevention, any kind of anticipatory guidance that may come up, you can get into that as well. But basically, the bottom line is we got to coordinate and address the goals of the parents, the athlete, the school, the organization, all while promoting safe participation in sports. So that's the fancy way of saying we're here to make sure the athlete is going to be safe in their sports participation. You should never be pressured into premature clearance of an athlete, never, before an appropriate evaluation is completed, even if tryouts are today and they're gonna, they're the best player on the team. This is my idea, this picture is my idea of an athlete and a parent and a coach all having different ideas. So that can happen on the, on the court or on the mat or, in your clinic office too. So, is it effective? Well, really, we can't predict the future. You can't always predict which kids are going to have the sudden cardiac death, the orthopedic injuries, the exercise-induced bronchospasm. But it's still, this pre-participation evaluation is still endorsed by the American Academy of Pediatrics, the American Academy of Family Physicians, a whole host of other sports and orthopedics societies. Why? Because, like we said before already, it helps establish a medical home. You can manage some chronic illnesses. You can use it as an opportunity for anticipatory guidance, injury prevention, that kind of stuff, and other lifestyle risk factors. So there's a lot of benefit to be gained, not just checking a paper and signing and say go play and have fun. So, is it standardized? If you're asking why, yes it is. There is this pre-participation physical evaluation put out by the American Academy of Pediatrics and Family Physicians, and then there's literally a whole host of other societies that endorse it as well. It's literally 180 pages now. The first came out in '92, but this fourth edition that came out in 2010 is 180 pages long. It has the goals, the setting, the structure, the ethical, legal considerations, how to do the history, how to do the exam, considerations for special needs children, all the research supporting all these things, all the forms and appendices you could ever want. So our goal is in the next 40 minutes we'll cover 180 pages worth of information, all while taking questions from you guys. So if you have questions, just shout it out. I won't have as many fancy, fun pictures as Dr. Pendleton, but hopefully we'll make it interactive so we're not reading 180 pages of boring stuff. So, okay, a couple words about the logistics. Who does the PPEs and when and why? MDs, PAs, APRNs, and then RNs in the school, like you guys, correct?
I don't think we can. No, we don't do sports physical.
Okay. Kentucky is one of 35 states requiring the yearly evaluation. And I have a little blurb from the bylaw saying it's only valid for 1 year. And Kentucky is also one of the states that makes participants have medical insurance as well. And there's also a little blurb from the bylaws that's saying requirement for insurance. Interesting fact there. So, what's that?
That's not enforced.
It's in the bylaw, so that's a goal. I should say that's a goal of the state of Kentucky is that to have insurance. So hopefully we're working towards that. So the most important part of the PPE, the pre-participation evaluation, is getting the history. Dr. Terrio was making copies. I actually have the KHSAA, the Kentucky High School Athletic Association form, the history page, and then on the back is the physical page, so you guys can peek at that in just a second. But really going through the medical history is a decent chunk, the most important part, really. There's a lot of different screening tools available, but just remember that you don't always have to rely 100% on the form. A lot of times there's additional history that may be needed. That's why we're not having, you don't just check off a form and go play. You actually have to see a human provider to get cleared. It may have to include medical, surgical, family, social, developmental histories, just like any other non-sports related evaluation in the provider's office. So she'll hand out our two-sided form here just to take a peek. It's pretty in-depth, and a lot of times should include the parent or guardian in some form, as the history can be pretty inconsistent from kids and adolescents. You guys see kids in school without parents all the time, so the medical history regarding family is sometimes non-existent, I suppose. But hey, I don't usually feel comfortable doing a sports physical without some type of parent, because there are a lot of important, even life-threatening family history elements that you'll see on the form. Exactly. I've had to break a couple of young athletes' hearts that they came in without a parent, and they need this form signed, and I'm like, we gotta do this with your parent. So remember that. Okay, so the most alarming red flag, significant piece of the medical history form is in regards to the cardiovascular history. And any of these things will require further investigation, usually by a cardiologist. So most of these will be covered by the checklist, but these are things that we go over and we should be asking specifically. So in the athlete or the family, is there any congenital heart disease? Is there any history of cardiac arrhythmias or what we call channelopathies? Things like long QT, Brugada syndrome. Have you guys heard of these? Long QT and Brugada are both inherited abnormalities in the ion channels of the cardiac membrane that can lead to literally sudden cardiac death. Even adults that have never had a problem before, these are things that if you see this in a family history, or if you see this on an EKG, this is the thing that somebody can walk out of your office fine and be dead that night, basically. It's kind of a scary family history. Wolff-Parkinson-White is WPW. That's another form of arrhythmia, not usually as often associated with sudden cardiac death, but can lead to SVT, that kind of stuff. Any history of myocarditis, coronary anomalies, meaning like abnormalities of the way your coronary arteries come out of your heart and wrap around. Any history of Kawasaki disease, any history of basically issues with exertion, whether you fainted because of exertion, you get dizzy, you get headaches, you get excessive shortness of breath, you get palpitations. Any of that stuff with exertion is worth noting and investigating. Any family history of sudden cardiac death, Marfan syndrome, or any cardiomyopathies. You guys heard of hypertrophic obstructive cardiomyopathy, or HOCM. That's kind of an important piece of our history as well. Any poorly explained death, and this may sound like a goofy question to patients or athletes or parents that aren't thinking about this, but if you ask about, are there any family members that had unexplained single car accidents or drowning, and they may not have put this together, but if you have a family history of 3 uncles that all died in single car accidents or unexplained drownings, you may have to investigate whether there is a history of some type of arrhythmia. So that's what you're trying to get out: seizures and arrhythmias if you're looking, or if you're asking about drownings and single car accidents. But it may not be, apparent to them just yet. Okay, so musculoskeletal aspect of the history. Really, you want to know about the history of injuries, current or previous. Now, if they had a hangnail last January, they may write that on there. But if you ask the questions in a certain way, you can get to the important ones. So if you say, have you had any injuries that require evaluation, casting, bracing, surgery, or missed games in practice? That'll slim it down to the important ones, I think. Or if you have any pain, instability, limitations caused by previous injuries, those are worth noting as well. And will help you decide whether or not they need further evaluation. And try to get surgeries documented in detail rather than just saying I had knee surgery. That could mean a lot of things. But if I had, bilateral ACL reconstruction from 2 separate injuries, that gives you a little bit more information. So try to get as specific as you can regarding surgeries. Medications, we always want to know what medications they are taking. There's always the patient or athlete that says, I don't have any medical problems, and then they list their medications, and then you have to go back a little bit and say, wait a second, maybe you do have some problems that you're forgetting about. But you within the medication umbrella, we consider vitamin supplements, even banned substances, if they're going to tell you about that. It's also an opportunity to ask about use of alcohol, tobacco, recreational drugs, all those things. And again, a chance for intervention or anticipatory guidance, that kind of stuff.
You talk to the student with the parent and without the parent?
So after they are 12 or 13, whether it's a well visit or a visit such as this or some other sensitive issues, we always do part of the visit with the parent and then ask them to step out. Yeah. Some parents are a little taken aback by that, but I'd say we do it for everybody, so just try to make it, once it's a habit, they did it when they're 13, 14, they're not going to worry about it when they're 15, 16, 17, so. Yes. Just a quick piece of history regarding skin issues. I know you guys just learned everything there is to learn about rashes, right? You can talk about a history of impetigo, molluscum, tinea. Anybody ever seen wrestlers with ringworm? A couple of people shaking their heads. Even herpes, it can be common in sports involving close contact with other athletes. You want to know, I think you guys talked a little bit about MRSA and treatment and that kind of stuff with Dr. Pendleton, right? It's also an opportunity to talk about sun protection, sun damage, that kind of stuff. I like to think this is a picture of athletes putting on sunblock and not admiring their guns or whatever. So more on history. So this is another hot topic, kind of a big issue these days. Yes, so under the umbrella of neurologic history, you want to ask the patient or the athlete about a history of concussion, a history of head injuries, history of stingers, or any instability fractures or changes in their spine. Does everybody know what stingers are? Anybody ever seen that or had that? So it's like most of the contact sports, football, hockey, that kind of stuff. If you basically after contact, you kind of stretch some of the nerves in your brachial plexus, and you have this transient kind of burning and stinging pain. Again, questions have to be specific with these young athletes. There are a lot of misconceptions and just lack of information out there. A lot of young athletes, hopefully we've educated coaches and athletes as best we can, but there are people that don't think, without a loss of consciousness that there's no problem, that there was no concussion without a loss of consciousness. So we want to try to educate people as best we can. If they do have a history of concussion, you want to try to get more detailed history. Ask about frequent concussions. Ask about being easily concussed, prolonged symptoms, this kind of stuff. And we'll come back to this in a moment. Is there a role of neurocognitive testing? Maybe. With more professional college-type athletes, they'll do some, and even some high schools now, they'll do some testing at the beginning of the year that they can later compare to after some type of head injury to see if they're still having some kind of cognitive effects or not. And a lot of these are still being tested and validated, but some are being used already. And just a quick note, the Kentucky High School Athletic Association does require that coaches attend a safety course, like a medical symposium, so they're hopefully better aware of concussion issues and whatnot. So what is the boring definition of concussion? It's basically rapid onset of short-lived neural impairment that resolves spontaneously, that is induced by traumatic forces to the head or the body that then transmits forces to the head. There's no structural abnormality on neuroimaging as part of the definition of concussion. But symptom-wise, it's not just loss of consciousness. It's way, way, way more complicated than that. I hope that doesn't come out too fuzzy, but basically there's 4 categories of symptoms with concussion: physical, cognitive, emotional, and sleep. In the physical, you can read there, it's a lot of the normal ones that you would think of: headache, nausea, vomiting, dizziness, that kind of stuff. Cognitive, we find a lot of athletes after having a concussion will have this feeling of being kind of slowed mentally or in a mental fog, that kind of stuff. It even there's emotional changes, it has its own category, as well as sleep changes. So there are a number of symptoms that you can see in the days and weeks after a concussion to think about. And those are all listed there.
Excuse me,
Yes.
can you explain the body, on the body, traumatic force in the body?
So you don't have to be hit right in the head to have a concussion. You can get hit in the body and it kind of moves your head in a certain way where you can be concussed, basically. Yeah, exactly. So it doesn't have to be, that helmet-to-helmet hit. It doesn't have to be, a hockey stick to the head. It can be a number of things, mostly involving collisions or some type of kind of collision, I guess. But basically the forces can be transmitted. They don't have to hit right on your head. Especially even getting kind of slammed to the ground. I mean, you can consider that direct blow to the head, but some of it is just the whiplash effect as well. Okay, a couple other things about concussion. Can we predict who's going to have the prolonged symptoms? Well, not exactly, not 100% perfectly, but if they have a high number of symptoms, if they have a history of previous concussions, if they have prolonged loss of consciousness, you can say maybe they're at risk to have prolonged symptoms. There's also this idea of the pediatric patient versus the adult patient, and we do know that kids and children and adolescents can take longer to recover from concussion than some of your college and professional athletes. You'll see NFL players that have the worst collision ever and they're back on the field next week. And they have rules in place now that they have to be evaluated by neurologists and such, but we know that kids basically can take longer than older college and professional athletes. What are the riskiest sports? Really the sports with higher incidence of collisions. Football and ice hockey for boys, and then soccer and lacrosse for everybody, really. When you look up girls versus boys incidents, at least in high school athletes, you'll find that boys have higher overall, but if they played the same sports, it would be girls overall, most likely. Basically, if girls played soccer and hockey with the same percentages that boys did, their numbers would be a little higher. So it's not just football players. Remember that. They're more likely to happen in games versus practice. A couple ideas about long-term sequelae, and this is important for our athletes with concussion. There are a lot of ongoing studies about this right now. It's kind of a hot topic, but they're starting to show some adverse effects on their neuropsychological testing and even GPAs with multiple concussions. So it's kind of scary. Then there's this idea of the second impact syndrome, and this is a little bit controversial, but again, we're starting to know more about this all the time. If you have a second concussion basically before the symptoms of your first are cleared, you can have much more dangerous and drastic effects. There's this idea that you get kind of vascular congestion in the vessels in your brain, and there's been a couple of cases where it can lead to cerebral edema and that. Post-Concussion Syndrome is what we call symptoms lasting for more than 3 months after a concussion. You can get fatigue, sleep issues, headache, dizziness, irritability, aggression, anxiety, all these personality issues for 3 months after. And this is if we're seeing this, they should probably be seeing some type of concussion specialist at this point. How do we treat? Are we really? It's not treatment as much as kind of a concussion rehab plan, really. And this is in bold. I can't state this enough with enough importance, but appropriate management after concussion is very, very, very important for reducing the risk of long-term complications and symptoms. So remember that. So what do we do with an athlete that is concussed? Basically, they need a period, at least a day of full rest, and that means full cognitive, mental rest. That means everything. No school, no homework, no sports, nothing, minimal TV, video games, not doing anything that makes their brain really think too hard about anything. And that's an important piece of the recovery. And then we do kind of a stepwise return to activities, including sports, after they're symptom-free. So we see a kid in the office with a concussion and they're still having headaches. Basically, we restrict them from all activities until their symptoms are gone. And then we say, the next day after your symptoms are resolved, you can try getting up and walking around a little bit. You can listen to some music or something that's pretty low stress. And then you monitor for those symptoms. You monitor for headache, dizziness, nausea, vomiting, anything like that. And if things go okay with that, then the next day maybe they can try school, a little schoolwork. And if that goes okay, they can progress from there. Now, if they take a step forward in their activity and then they get a lot of headaches, a lot of dizziness, a lot of nausea, then you're back to square one. You have to start over. So this can take a long time, and it should take a long time to get back to full activity. And this can go for school stuff and sports. So it may take some education even of teachers and other people in the schools, like what is expected of a kid, after in the immediate days after a concussion. But if you're thinking of it strictly in terms of sports, after you progress, you've had your day of symptom-free, then you're doing a little bit of activity and you're still symptom-free, and maybe you can start a couple non-contact drills, and if that goes okay, the next day you can do more full contact drills, and if that goes okay, the next day you can practice. If that goes okay, the next day you can play. But basically, we go through all these steps to monitor for return of symptoms, but it also gives us at least a week. They should not be returning to full gameplay before a week. And this kind of helps us get to that point in a logical manner. Bottom line, if you think a patient has a concussion, they should be held out of sport for at least a week, and they should follow up with a healthcare provider towards the end of that week for a review of symptoms, etc. And never ever allow a symptomatic athlete to return to play. So that should be a given, hopefully, at this point. When to retire, this is an interesting field, I suppose. And really, the bottom line is there's no evidence-based guidelines for when to officially pull an athlete from a sport. But there's this idea out there that if they've had 3 concussions in one season, or if they've had symptoms for more than 3 months, like that post-concussion syndrome, then you should really consider a prolonged period of time away from sports. And if the provider is not comfortable making this determination, then they should refer to a specialist with more expertise. But it's hard to make a teenage athlete retire from their sport, certainly, but you have to be having these conversations with patients and families about long-term sequelae and that kind of stuff. Ontario, just give me the other handouts about heads up. So this is probably the most important thing I could give to you guys today. If you remember nothing else of what I've said, please remember this heads up as a resource. This is put on by the CDC. And basically, if you just Google CDC heads up, you'll find this tremendously awesome website all about head injury, both from sports and also kind of like helmet education, that kind of stuff. It has everything. It has information specifically for teachers, coaches, parents, athletes, everybody. There's training materials for teachers and coaches. There's these customizable handouts that you can like put your own logo on, and I've given you a few there. They look much fancier in color, I suppose, but it's got everything from basics to like the guides for recovery and return to play. They have an app for your iPhone. They kind of have it all. It's a really, really awesome website specifically for head injuries, concussions, helmet education, all of these things. So please remember heads up, if nothing else. Okay, so back to we're still doing our history in the sports physical. You want to know if they have any baseline lung disease that may require any additional evaluation before the season. If they have any exercise-induced bronchospasm or asthma, they may need to use a bronchodilator before activities. This should be all part of our history. GU has some very specific pieces of history, certainly if they have a solitary kidney, if they have a groin pain or inguinal hernia. You can also use this as an opportunity to evaluate for what we call the female athlete triad. Have you guys heard of this? Disordered eating, amenorrhea, and then less than ideal bone health, I should say. So this is a miscellaneous history page. So do they have any history of heat-related illness? Do they have a history of any eye injuries, chronic eye issues? Are they functionally one-eyed? And we'll come back to that, what that means. Do they have anemia? Have they had recent mono or EBV infection that should hold them out of contact sports for 3 or 4 weeks? Do they have immunizations? All these are part of our pre-participation evaluation history. And then you have your form there, hopefully. It looks a little different. They actually just came out with a new one in April of 2015. So if you guys are seeing older, outdated ones, then this is kind of the new version. And again, going back to having parent available, on the front it's got some very technical language on there, specifically about family history. I don't know how many young athletes you're going to know if they have catecholinergic exercise-induced ventricular tachycardia.
There's middle school and now high school form.
Yeah, I should have put them side by side, but I was thinking that they were pretty similar, correct? The middle school versus high school, I think that they are. Hopefully. That's the website. If you guys ever, if you can search basically the KHSAA PBE form, it'll take you right to it. You don't have to muddle through their confusing website. But. So now what? You've gone through an exhaustive history, reviewed their form with you. You probably should do a little bit of a physical exam, right? So what do we start with? Always the vital signs. I have to have height, weight, BMI, temp, heart rate, respiratory rate, and blood pressure. Some important things can come from this, specifically their blood pressure. If they have severe hypertension, we always compare blood pressures to their height and age matched controls. So there's dizzying charts full of numbers of the accepted or the percentiles for each height and age for their blood pressure. If they have severe high blood pressure, we should think about warning them against weightlifting, powerlifting, that kind of stuff. And always do a visual acuity. It should always be a part of every pre-participation evaluation. It should be corrected at least 20/40 in both eyes. So if you are corrected as best you can be corrected, and you're less than 20/40 or 20/40, you're considered functionally one-eyed. If you're less than 20/40 in one eye, you're functionally one-eyed, and that's an indication to wear a specific type of eye protection. Basically, if you have one working eye, you want to protect that one if you're playing any kind of sport. Okay. So cardiovascular part of the physical exam. Really, we'll get to more about pulses and other interesting things in a moment, but you want to look for or listen for a murmur. Do they have a known history of a murmur, or is it new? Has it been evaluated before? And exam features of the murmur, you want to know the timing. Is it systolic? The location, the timing, the quality, the change with position, all of these things can be important in our history. Have you guys graded murmurs? Is this looking
It's either
familiar?
there or not.
What's that?
My opinion, it's either there or not.
Good, good. Hey, we don't see too many that you can hear without the stethoscope. So basically, you'll find a lot of people saying grade 1 to 2, which means you hear it with the stethoscope, but it's not incredibly loud. But there is a true grading system, 1 through 6 there. And basically, if you can feel it with your fingers through their chest, it's at least a 3. So most of the ones that we will hear are going to be 1 to 2. So grade 3 should be what we call a medical student murmur. Even the medical student can hear that one. So features of an innocent murmur in general, and this is not 100% all the time, but in general, features of an innocent murmur are going to be early systolic, going to be short, going to be grade 1 or 2, and it'll have like a vibrating or musical type of quality. Does this type of picture on the bottom right look familiar to you in terms of where to listen for each valve? Okay, can you guys see that? It's kind of small. What's that? Is that how you remember it? All right, what's that mean? Is it like a little mnemonic that you have?
Yeah.
What is it?
What is it?
I don't know if I learned it that way. Basically, you're looking for your aortic valve right over here, and that's in the second intercostal space, right on the right side of the sternum. When you're looking for your pulmonary valve, you're in the left second intercostal space, right up against the sternum. And when you're looking for your tricuspid valve, you're in the just against the sternum in the left fourth intercostal space. And then when you're looking at your mitral valve, you're more in the midclavicular line in the fifth intercostal space. So those are the places we should be listening every single time. So a couple things about some important murmurs. We mentioned hokum earlier, right? Have you guys seen this picture on the bottom right? Have you guys ever seen what hokum actually looks like and why it causes a problem? So the middle wall of the medial wall of the left ventricle is literally so thick that it blocks the outflow. So your ventricle is supposed to be pumping blood into the aorta here, and it gets so thick that it basically blocks your output. And that's why you see and hear some athletes having sudden cardiac death, basically. What was the guy's name? There was a Celtics player in like the 80s, Reggie Evans. Do you guys remember that one? Remember Hank Gathers from any of these people sound familiar? Yeah, basically. Well, but it kind of develops over time. So it's not really there at birth, but it's kind of an inherited type of issue. But it may not cause them a problem until they're a little older and really exerting themselves. So just remember, regarding hokum, it's a systolic murmur that can get louder when you decrease the venous return. So that means if you have them do the Valsalva, like bear down, or if you even just have them stand up to decrease the venous return, this murmur will get louder. And that's kind of the opposite of most innocent murmurs that you see. So if it gets louder when they stand up, that's bad. Basically, that's the way I remember it. It's basically because you have less venous return, that ventricle is not as full, and the obstruction gets worse. Now, if you have them squat and that ventricle gets more full of blood, it opens up a little bit, so the murmur is softer. Is that as confusing as can be? Okay. So, in contrast, I just wanted to put these two in contrast for you because these are two of the more important ones to know about. Still's murmur is like your classic innocent murmur. They gave it a name, but you can call it innocent murmur. It's systolic, it's vibratory. It literally sounds like kind of blood flowing past a guitar string almost. It's got the little, like a vibratory sound to it. It's usually a grade 1 to 2. Most common in the younger kids at the left lower sternal border. And this one actually gets louder when you lay down, and gets less when you stand up. So opposite, right? Okay. Okay. Some other fun aspects of the cardiovascular exam. You want to always palpate femoral pulses. You can help rule out any aortic coarctation. I've had colleagues that picked up coarctation in teenage kids, so it's not always just a first week of life problem. We'll look for physical stigmata of Marfan syndrome. You guys heard of Marfan? So this is a disease, really has to do with some of your connective tissue, but it causes a lot of problems, most importantly, aortic root dilation. But there can be some other signs. It's these really, really, really tall, long, skinny folks that we get a little nervous about. This is a picture of Isaiah Austin, who played for Baylor, played all through high school, played all through college, no problems. Finished college, went to the NBA draft, evaluation, had an echo, and was found to have Marfan. So we kind of slipped through the cracks, could have had a serious problem at any time, and then this guy thinks he's going to spend the rest of his life in the NBA, and then one day they say, sorry, you can't. So they can slip through. But you want to look for things like the thumb and wrist sign. So if you see someone that's really, really long and skinny, and you're like, how do I look at Marfan's more, or look for Marfan's a little harder? The thumb sign is if you put your thumb through your palm and the whole first phalanx sticks out, that can make us think that your digits are a little long. And then this wrist sign, does anybody have their thumb sticking out when they do this? I don't know if I'm doing anything I'm seeing in sign language or anything, but the wrist sign, if you take one hand and put it around the other and try to overlap your thumb and pinky. And if your whole first phalanx, the whole tip of your pinky and the whole first phalanx of your thumb overlap, that could be a problem. I can't even get close. Anybody? It's your pinky, not the. So those are little signs that may make you think you should get an echo or look a little harder.
There's another sign too that you can pick up on with a kid that has a decreased depression right in here. My son, and the reason why I know that, my son had a friend, and his friend could actually put a bowl of cereal and eat it out of his chest.
So we see kids with pectus excavatum means in, and then pectus carinatum means it's kind of sticking out.
Yeah.
But yeah, that could be associated with it as well. The bottom line is, we're doing our physical examination. We find anything abnormal, any cardiac abnormality, a new murmur, some Marfan signs, anything like that, a family history of some arrhythmia that scares us. Any of these should be evaluated by a pediatric cardiologist before sports participation. It may actually save a life someday. Okay, back to the rest of the history. If you have one testicle, you should really be counseled to wear a protective cup. Same thing with the eye. If you only have one, you should really protect it. Hopefully these kids have already seen a urologist. Not every single male athlete has to have the evaluation for the indirect hernia, but if anybody that has any kind of groin pain should be evaluated for that. Okay. More on the physical exam. We're going to go over what they call the 2-minute screening musculoskeletal exam. And again, this is a screening exam. It lasts 2 minutes. It's not the most comprehensive exam you've ever seen, but it functions for the vast majority of sports physicals. It may need to be supplemented with a more comprehensive exam for anybody with pain or other issues, weakness, etc. And it may lead to specialist referral if needed. So will anybody volunteer? I need 3 volunteers. Just to stand right up here. Does anybody have an iPhone on them or a timer? All right, so somebody who...
I'm not.
You can be the patient, you can be the provider, and you just got to be the timer. You can actually say. So put the timer on. If you have one that counts up, right? And we'll see how long this takes.
It'll take me longer than 2 minutes.
All right, so no, I'll help you.
Let's
see. All right, tell us when to go.
I
I got the number.
Thank you.
We're ready.
Stopwatch. Okay, just hit start. Okay, here we go. All right, ready? Okay, so step one. Make her stand facing you and inspect for symmetry. Actually, your head's in the way a little bit.
Sorry,
Let's go over just a little bit. A little bit more.
This way?
Okay, have her stand in front of you and inspect for symmetry. Good.
Perfect.
Okay, make her flex her neck forward, extend it back, rotate every which way, laterally, making sure she has normal range of motion. Good. Okay, put your hands on her shoulders and tell her to raise her shoulders against your resistance. You're looking for resistant shoulder strength. The strength of the traps. Just the shoulders. Okay. Okay. So she was going on to number 4. So now the deltoids. Hands out to the side and try to push up against resistance.
On her hands. Don't go out your hands. There you go.
Good. Push up against resistance. Good. All right. Let's see. So number 5, we're checking our shoulder kind of range of motion. So bend your arms at the elbows and flip them down like this. We're going internal and external rotation of your shoulder. Nothing fell off or anything.
It pops. I'm a pop.
All right, we're going to do that a little bit more. Okay. Hands out to the side like this. And bend your elbows right and left. Try to see kind of full range of motion there. Okay, so number 7, put your hands out. Now we're just doing pronation, supination of your elbow. Full range of motion, no pain there, no swelling, nothing looks too crazy there. Okay, so number 8, you can put your hands out and make a fist and then extend your fingers. Good, looking at range of motion, good. Okay, so number 9, make her turn around, make sure everything looks symmetric. Good, okay. And so number 10, make her bend backwards at the back.
This way.
No pain, good. All right. All right. So then make her bend over just to look for symmetry in the back, facing away from you, and then turn around and facing you. So bending over there. Good. Okay. Number 12, stand straight up. Ideally, they'd be wearing shorts or a gown, I suppose. But basically, you flex each quad. You flex the left and flex the right, and look for alignment and symmetry.
It's there.
It's there. All right, so the hardest part is the duck walk, okay? So can you bend all the way down? All the way down like this.
Oh, squat. I don't know if I can back up, it's a problem.
But if you make an athlete squat down like this and then do what we call the duck walk and take a few steps.
I'm gonna hold on to something.
So it tests strength of hips, thighs, ankles, balance, all these things just in one little duck walk thing, okay? Symmetry, alignment, strength, balance, range of motion, all that stuff with one little test. Okay, and then number 14 is walk on your toes and then come back towards us on your heels. What's the time? You were slow. Sorry. Thank you. I think we could shave off a couple minutes, right, if we had to, or a minute. But basically, that's your screening exam, and if you find problems in that, then you can look further, certainly. Thank you very much for helping.
I have a question.
Your knees aren't hurting now.
No.
Yes, ma'am.
Like on the scoliosis screens,
Sure.
you know, I can look at a back and I can see that everything, but still the curvature of it. I'm not sure when it's considered more of a problem or just normal, you know, little curve.
That's why they invented X-rays, right? No. So if you're worried that there's curvature, I mean, you should probably get an X-ray. And there are some kids that have, you know, a few degrees that we don't do too much about, other than get an X-ray every 6 or 12 months to make sure it's not getting worse. But you know, once they get above 10, 20, then you gotta start thinking about doing something about it. So if you can see it with your eye, it's not even the kids that have the S shape. Sometimes when they're bent over and you're running your hand along their spine, and you feel like the ribs and musculature of one side is higher than the other, that can be an indication of a little scoliosis too. But sometimes it twists like this before it actually curves over.
But what about like just when you're looking straight on and it just seems like
Are you talking about
It's
just
their normal lumbar?
Yes, it's like almost like
So not side to side.
No, not side to
So they have a
side.
little lumbar lordosis and then
Yeah,
a thoracic
I mean-
kyphosis, right?
Yeah, but it's just seems like a little bit more than normal. But I mean, I don't know what really seems like too much or more posture.
It could be posture, it could be just the way, some people have more kyphosis there. But if it's,
Some of them depends on gymnastics. Like gymnastics, my daughter has it at her back, but it's because she's a gymnast. She's been a gymnast since she was 4, and the bending and everything, the muscles are tighter. So it depends on what.
So I thought you were talking like a right and left thing, but if it's just the lordosis and the kyphosis, if they have good range of motion and it's pain-free, then it may be just postural. Now you think about people that have pain when they bend backwards. If you're looking for a thing called Spondylolisthesis, and it's mostly in people that have like extreme back bending in their sports, like butterfly swimmers and gymnasts and something else. But basically, if your vertebrae kind of slide away from each other in a certain way, it can cause pain in the lower back. But so that's why that back bend is in there. But usually a problem with gymnasts and butterflies. Does that help? There's a couple other knee maneuvers. We'll skip through this. This is more looking for specific ligaments, damage, etc. And then you have your sample history exam form, hopefully in front of you as well. And again, don't forget height, weight, all the vitals up there at the top. All of those things need to be included. So what does clearance mean for sports? So we think of that in kind of 4 different categories. You can clear without restrictions. They're have a normal exam, no red flags on the history. They're good to go. You're reasonably reassured that they're going to be healthy and pain-free and symptom-free. You can do clearance with recommendations for further evaluation. Like you might want to get that funny-looking toe checked out. You can also say you're not cleared until you get, your cardiology evaluation or until you get this echo and we assure ourselves that we don't have some kind of dangerous problem. Or you could say you're not cleared for anything, or you could never play football again. You're not telling somebody that they can't go run, but you could say you're not cleared for a certain activity. So there's kind of different categories there in terms of clearance. So what if we're asked to clear somebody after an injury? So in general, after thinking about sprains, strains, dislocations, overuse injuries, you guys ever heard of Little League elbow, anything like that? Common thing in young athletes, but you should really be basically have a pain-free range of motion of the injured joint, have no minimal or no swelling, have near normal muscle strength, and no pain or instability with your activities that you're going to do with that sport. What are some special circumstances in terms of pre-participation evaluation? So if you have uncontrolled epilepsy, you can do a good number of sports. But kids with epilepsy, whether it's controlled or not, are usually restricted from doing things like archery, where somebody can get hurt, riflery, swimming, weightlifting, and then sports involving height. So just something to think about. Not trying to make a joke, but it's just something to think about. Down syndrome or trisomy 21, the Special Olympics has their own imaging evaluation requirements, because a lot of times they'll have that atlanto-axial instability in their neck, and so sometimes they'll need plain films of their neck before they can do certain sports. Acute febrile illnesses should make you aware of the risk for heat illnesses or heat-related illness, reduced capacity, hypotension, all these things. And in kids with type 1 diabetes, their participation is not prohibited, but monitoring can be a little more time-consuming or complex. So do we do screening tests with every pre-participation evaluation? No. In 2007, this American Heart Association took a look at this and how many injuries or deaths could we really prevent, and what was the cost, and what was the cost of all the follow-up of uncertain findings on screening tests, etc. And they did not recommend that we do EKG or echoes on every athlete. There's a lot of false negative. There's a lot of unnecessary workup because of those. And really, they looked over a span of several years, and there was no change in the rate of sudden cardiac death or death of athletes. However, if you look at some of the studies done from Italy, They actually do recommend this screening, and the International Olympic Committee does some of these screening EKGs with those too. So kind of interesting. Once you get into the higher levels of sports, and especially professional sports, if somebody's going to invest millions of dollars in your play, they're gonna make sure that you have a good echo, certainly, but not recommended for every middle school and high school activity. So how can we improve the pre-participation evaluations in the future? Some people have talked about making it on web-based, so you can kind of make it more efficient. You can make it more extensive in terms of the history part. You can have them do it ahead of time. You can have them update it or have the same form from year to year. And we could always improve the standardization and the follow-up of our patients. These are just some thoughts of mine, I should say, regarding our improvement of this function. Let's see, what's time we have? Secretary?
Oh, I think you have time.
We do a couple questions? Okay. Questions are always fun, right? They make it hit home a little bit. So, say you're seeing a 15-year-old boy for a sports participation evaluation. He's the center on the basketball team. Maybe he plays a couple other sports. His height is over 95th percentile for age. His arms and legs are long and thin. And arachnodactyly is the term for long fingers, basically. And he has pectus excavatum, which you mentioned earlier, I believe. He does wear contacts, but no other visual complaints. And nobody really in the family history has any similar physical features. So what are you most likely to recommend? That was B?
B.
Good. This kid needs an echo, right? Could have been Isaiah Austin someday back in the past. Aortic root dilation is basically the most concerning finding associated with Marfan syndrome, and one that could really prohibit her participation. So, good. Okay. Here we go. We have a 12-year-old ice hockey player. So girls are playing more hockey these days. I know we talked about this with concussion. Maybe their numbers will come up a little bit. Hopefully not. But basically, she comes in for a sports physical. She wants to play in a game that day. The only absolute contraindication to participation would be what? Not necessarily. D is, that's one of those happy murmurs, right? Innocent murmurs. So really, having an acute febrile illness is really the only absolute contraindication for this person. It just puts her at higher risk for some of those issues that we talked about earlier.
So what is that?
Sorry?
What is it?
What is it, Tim?
Oh, sorry. So 38.8 would be, so 100.4 would be 38. 38.8 is like 101.
Yeah, that's the one.
101.
We would pick that.
Okay, sorry. I'm glad you said that, because I'll change it before next time I give this to provide Fahrenheit, so everybody knows what we're talking about. Everybody's in the form we're most comfortable with. Okay, 16-year-old coming in because of an injury she had while playing soccer. Player hit her in the chest, causing her neck to snap, her head to snap back. We were talking about this basically injuries that aren't directly to the head. So she got hit in the chest, her neck snapped back. She had a headache and nausea immediately that lasted several hours. She did not lose consciousness, but she seemed kind of forgetful and been having trouble sleeping. So what are you most likely to tell the girl and her mother?
Refer to doctor.
Good answer. Don't play soccer and go see your doctor. That's as easy as it gets, right? Good. Rest from all activities, follow up with your healthcare provider. Not necessarily that she has any imaging, but know that concussions can happen without loss of consciousness, without even blow directly to the head, all of these things. And know that the symptoms, like we said earlier, can be physical, emotional, cognitive, and sleep. All right, one more here. 14-year-old comes for a pre-participation physical evaluation. I can't say PPE, so it makes me think of personal protection. I can't say PPE, but anyway, so she saw her ophthalmologist magically before she saw you. And the best corrected vision is 20/20 in one eye and 20/50 in the left. What's your most appropriate recommendation for this person? E. You gotta protect the good eye, no matter what, right? You only have two. If one of them's not working so high, you gotta protect the other one. So wear protective lenses. I swear I think this is the last one. This one's kind of different, but 7-year-old comes in because mom says she has intermittent bilateral knee pain with activity. She has no swelling, no limp, no fevers, no skin problems, no change in level of activity, no changes in appetite. It doesn't really limit what she does. She just complains every once in a while. And when you're doing the exam, or maybe even mom brings it up, that she's kind of can hyperextend the knees and elbows past 10 degrees. And mom says a lot of other people in their family are like this.
Is it Osgood-Schweitz?
No, it's a little different. That's different. That's more of a kind of a. So that's where we're headed. She doesn't truly have Ehlers-Danlos. What I was going to say about Osgood-Schlatter's is it's kind of a inflammation at the connection of the tendon and bone, and they kind of
So it's not double jointed.
It's not really double jointed, but it's what's the word I'm looking for? It's an apophysitis. Sorry. So where the tendon connects to the bone is the apophysis, and they get inflammation there from recurrent use in pre-adolescent people. So. Really, this kid, if it's not limiting her activity, she doesn't have any other findings of Marfan's or Ehlers-Danlos. You really don't have to do too much about this. There are just some people that have some joint hypermobility. So know that. If it's affecting her, if she's not able to do things, if she has severe pain, if she has swelling, redness, warm knee, anything like that, yeah, you got to look a little further. But there are some kids that have a little bit of mild ligamentous laxity, and it doesn't really cause them a problem. And it's not a big deal, so they can do whatever they want regarding sports. That's it. Questions? Yes.
I get kids that are in the meeting where it's playing with and they've got full range of motion without pain, and they're walking normally, they're not injured or any other symptoms. Sometimes I think it's just growing pain. Is that such a thing?
So do they say it hurts worse like after they have a day of activity, or if they're going up or down stairs, things like that?
I've never had that question.
So there are a lot in pre-adolescent or even adolescent athletes or any teenagers. There's a lot of these what we call apophysitis type of condition. So Osgood-Schlatter's right at the bottom, at the tibial tubercle, if they have, like right where the tibia attaches to the patellar tendon, if they have a big, painful, like protruding nodule there, that's a sign of Osgood-Schlatter's. But there's a lot of other forms of that can cause this pain. Growing pains are more like, I think of younger kids in the middle of the night that just have cramping pains. But if it's something that is kind of focal, if you can press right on their tibial tubercle and they basically jump off the table, that's an indication of Osgood-Schlatter's.
And what is that exactly?
Yeah, so I have a different talk. Can I jump out real quick?
Sure.
I think I have one about overuse injuries, if I can do that real quick. It won't take too long. Maybe. I can incorporate this. Little League elbow we mentioned. Do you ever see kids with heel pain? Is that on the same? Severs, yeah, maybe it's severs. You may be right, but severs is a problem at the heel where the Achilles tendon attaches to the heel. These kids get usually like in that 7 to 15 year range that are active in running sports. They get kind of tenderness, or they basically just complain of heel pain. And it's just one of these apophysitis type of injuries. I wanted to mention that one and Osgood-Schlatter's and show you this picture. Usually running, jumping sports, that kind of stuff. So if you can see right where the there it is, right where the tendon attaches to the knee, like this is all just inflamed and painful, and it's just a common occurrence basically in pre-adolescent athletes, or even kids that aren't even that athletic that just run around. It's just a function of growing. So is it growing pains? Yes and no, but it's a significant source of pain, but it's usually localized right at that. See where this guy's knee has a big painful nodule right there? That could be a sign of Osgood-Schlatter's. There's also one called SLJ that's more like what they call Jumper's knee, and it's just a patellar tendonitis. And then there's yeah, those are probably the main ones. So really,
is that something that goes away with time, or does that need medical treatment?
So you can treat symptoms. You can put ice on it, use one of these little knee straps. But really, until their bones close like the growth plate, they can have recurrent symptoms that'll come and go and get worse the more they play or run and all that stuff. But once they grow up and their apophysis closes, it'll go away eventually. Now you can still have tendonitis later, but this type of Osgood-Schlatter and Severs is basically only in adolescents and pre-adolescents. So that may be, try to ask if it hurts more after activity or more like when they're going up and down stairs. That's classic for Osgood-Schlatter's and the Stigmata-Johansson or SLJ.
I've seen kids that had a concussion and they wear a headband like in soccer. Well, what's the headband do? I mean,
so is it a pad?
Well, I'm assuming it is.
So it is not. It doesn't absolutely prevent concussions, nor do mouth guards, nor do So they studied this. I think specifically in girls soccer, trying to make them wear like a soft kind of foamy thing, and it didn't really prevent them.
False security.
Yeah. So if you bump up against somebody's head, I mean, even if you're wearing a football helmet, if you collide hard enough, the force is transmitted and you're concussed. So it doesn't matter, what you wear. I mean, if it makes them feel safer.
Well, I thought, well,
maybe
they're wearing after they get a concussion. Why don't they just do it before they ever have one?
Well, that's the thing. If they worked and they prevented concussions 100%, then everybody would wear them. Okay, so that doesn't. And mouth guards certainly protect the teeth, protect all that stuff, but it doesn't keep you from getting concussed either. I think that was a myth a while back too. But it doesn't work as well as they may be hoping it does.
So this all looks very detailed. Then why do the little clinics of the world do this?
Because they can get paid for it, I guess.
Yeah,
Not to if they get concussion.
I didn't know that.
They're not supposed to if they've had a concussion within a year. Because when we were there was a lady that literally was arguing with the nurse practitioner or whatever because she could not go it because they had more concussion. So the mom said, see, we should have just changed it.
What stops her from going to the next clinic down the street and saying no? So it makes it a little bit worrisome that clinics that don't know the patient and have no follow-up.
Instead of their regular doctors, because they don't know.
Exactly. So any chance we could get to foster the medical home relationship, I think we should take that and try to.
But insurances don't pay for or the sports physicals, and you can go to your Walmart and get it cheaper as well as free or
I don't know if chiropractors.
They can't sign off.
Yeah, the chiropractors can't sign off officially in Kentucky as well.
At the elementary level, they do them for elementary school. Participation in basketball or soccer.
Again, it goes back to that first slide about your goals. That should make the school nervous, but if the school transfers the liability to somewhere else, then how much do they care after that? I'll let you guys eat. Do you have any other questions?
All right, Dan, that's 45 minutes to eat. Sharp at 12:15.